thanks for the invitation and the opportunity to be here. I was just asked before if I have been to Taiwan, and I have been here a couple of times. Actually, I had to renew my passport, not because it expired. I had no more stamp, pages in there, and going through the stamps, most stamps were actually from Taiwan. So a long relationship with that country, with industry partners here, clinical partners, really one of my favorite places to come here. And Robert, we met like 4 or 5 years ago. Time is flying, it's unbelievable. And really enjoying not only the technology partnerships we have here, but also the clinical ones. And so in that context, I want to compliment Jay's presentation, which I just got the first part, somehow not the second, not quite sure why. More from a clinical perspective, right? So Jay did a nice job telling you about the technology itself. The device, particularly this last form factor, is fantastic. Everywhere in the world, we have a lot of partners. I show this, they're really excited and want to get their hands onto that. And so Jay is under pressure to make that happen. So it's not just about Asia here. We talk about India, we talk about Europe, we talk about the United States. Jay was talking, that's one slide, the patch is really coming. Everyone wants to have a patch, it's a nice form factor. But a key portion to that is it's not only about technology, right? Technology can have different form factors. At the end of the day, it needs to make a difference. It has to fit into the clinical care cycle, and it has to provide clinically actionable parameters, right? So physicians are not just enjoying the form factor of it, they want to actually have a parameter. When they look at it, they know what to do. And not necessarily being kind of competitive to other things they have, it has to be synergetic. It has to make a difference on the clinical side, but also, we talked about this morning when Robert was talking about healthcare costs going up, exploding, population growing, we get all older, right? More diseases coming naturally. Certain diseases are now just popping up, like Alzheimer. They existed before. We just get older and the prevalence is getting higher, right? So it really has to fit in this whole kind of care cycle. And that's what I want to do a bit here with the slides. I promise it's going to be shorter than Jay's. To give you some example why it is really important to do the right clinical research to demonstrate then to physicians and the economic system that the technology can make a difference, okay? So starting kind of high level, WHO statistics, luckily, infectious diseases is not the #1 cause for death anymore. It's NCDs, and if you look at worldwide, NCDs are actually responsible for 70% of all deaths globally, right? And the biggest factor out of the key NCDs is really cardiovascular disease, right? For the most death, followed by cancer, respiratory diseases, and diabetes. And the actual breakdown and list kind of changes a little bit. Sometimes cancer is #1, sometimes cardiovascular disease, but these are the real main reasons for the health issues we have and the economic factors associated with it. Obviously, lifestyle is changing, less activity, tobacco use is still a key factor there. Diets haven't changed. There are kind of a lot of risk factors, which, frankly, you have those risk factors until you have the symptoms and you go to the doctor and they confirm it. That's when you really get serious about it. So this whole idea about prevention, is still growing in everyone's mind, but one of the key challenges is kind of having objective data in front of you to understand that the risk is really there. So this is where also a key element comes in. You have to actually detect and screen for it, right? We had some other talks before, in order to make a difference in that area. So thinking about cardiovascular disease diagnostics, the pyramid, obviously, the hospitals have the best equipment, right? But it takes a lot of time. It's very costly to do the right diagnostic there. Ideally, you want to have the diagnostic down in the primary care setting, right, with some simple technology. And specialists kind of go, obviously, on both sides. Thinking about, you see, I'm a technology guy, but can't really use this thing here. Come on. Up, down, left, right. Got it. Okay. Yeah, so on a very high level, there's more gray zones, but everyone understands ischemia, acute coronary syndrome, chest pain, right? Everyone is afraid to die of a heart attack, and this can happen. Not much of that detection actually occurs in the primary care setting, right? It's really, once you have the chest pain, it's clear, you know, the ambulance comes and brings you to the hospital because the best care is there. You can have early signs of chest pain where you can do a stress test, an echo, you know, biomarkers, they help you. But at the end of the day, the best care you actually do get regarding that in the hospital. The other kind of cardiovascular disease understood is arrhythmia. So people with syncope and, you know, dizziness. Jay was talking about a Holter. That's where the patch nicely fits in. It's even that, just ECG only is going to make a difference. But at the end, again, within the hospital, you have the best care. Now, heart failure is something I had to, you know, the last 10 years working on this technology, really seen a total change. At the beginning, it wasn't that quite clearly understood, right? Again, it's one of those phenomena where we get older, the heart gets weaker, but in particular here, either on the specialist side or in the hospital, it's not so easy. It's actually really a challenge to do the right diagnosis and manage those patients. They're highly complex, and you have to kind of fine-tune them. But the biggest problem is actually, in the first place, detecting heart failure early enough to make a difference. To give an idea here, heart failure, global economic problem, about 70 million heart failure patients globally, that's estimated. To be honest, nobody really knows, because, you know, there are no diagnostic methods going out into rural areas, other areas, to understand how many people do really have heart failure. They are basically showing up once they kind of hit the hospital, and that's where typically the first kind of diagnosis is made. In the US alone, 800,000 annual new incidences. In Europe and US together, kind of 96 billion expense per year. So from a US perspective, that's our key challenge, really, from an economic side. And Medicare is obviously paying for that. And the reason is not necessarily that it's, you know, what's kind of missing in the diagnosis. Those are very, very complex. Heart failure patients have other diseases. They might have arrhythmia, they might have, you know, sleep apnea, and so the symptoms sometimes mask it, right? Someone with atrial fibrillation can have shortness of breath. You treat the atrial fibrillation site, but, well, actually you found out this guy had also heart failure. And in the US, it's still a number which is true. 80% of the first diagnosis of heart failure actually occurs in the emergency department, right? Comes to the point, you can't breathe anymore, call the ambulance, go into the ED. So really, to make a change in this area, in particular heart failure, is the need to bring devices, technologies on a simple level really into the primary care side, right? And this is where really the device Jay was talking about can help. And so from a diagnostic, from a technology perspective, going back to where we started at Innovice Medical, we really wanted to make a difference. And if you think in terms of what we already talked about, on the one hand, the best care you probably get in the hospital, right? But you pay for it. You have to have, you know, the cost is high. You have the specialist actually interpreting the data. So the highest utility, you basically, you know, get what you pay for. On the other hand, you know, here would be the area where you really have the more affordable diagnostic, even driving prevention in the home. You have over-the-counter, like blood pressure and other things in here. But what's kind of missing is a technology which brings the high, you know, valuable clinical utility over into this more affordable price range. And that's what this AudioCore technology is. Jay talked about it, so not spending much time of it, but just on a high level, it's the combination of the classic electrical signal, ECG, in any kind of variation. By adding heart sounds, we actually add mechanical information, right? So the heart is not just electrically, you know, active, but it's kind of the key function it has is to get filled and pumped, right? And so you get really this information through the heart sounds. And the sensor is very simple. So we talked about the dumb accelerometer becoming actually a smart sensor, right? That's exactly what it is. The technology is really more in the algorithms, with the technology evolution. Why are we now able to do that? Well, the old photocardiography was around. It was great technology. Echocardiography came along, nice pictures, very good technology. But photocardiography was cumbersome, right? Now you have computers, speech analysis. We listen to the heart, interpret the data, makes the whole thing really much easier. So not only the clinical utility is there, we can also help more patients. So if you look at numbers in the United States, and this might be some older ones, but it's roughly still the kind of idea, 4 million arrhythmia patients, there's 6 million heart failure patients, where the electrical signal alone doesn't really provide any utility in the diagnosis or the management of those. And now you think about other comorbidities like sleep apnea. In the United States, about 20 million plus. Nobody knows the exact prevalence either, because not everyone typically gets a sleep apnea screen. But there's a strong overlap, right? Cardiovascular disease and pulmonary disease are not isolated, and sleep apnea is actually a highly comorbid state in those patients. So, as Jay pointed out, there's the short-term wear or even the diagnostic side, but also important is those patients do not only need to get diagnosed, they need also to get managed. And so the kind of long-term wear in a more like over-the-counter fashion that it fits into the daily life, this is really where this technology also is making a difference. Not spending much time, Jay showed you a similar diagram here. When you think about diagnostics, you typically think about the home to hospital, the first screening diagnostic part, where really, and that's the theme here obviously with digital health, we talk about the prognostic side, which is the key element if you really want to bring the hospital more to home, right? It's about diagnosed patients. You just want to keep them healthy, you want to keep the cost low, and so really on the one hand, kind of driven here by specialists in the hospital, and long-term future really having more an impact looking at the over-the-counter side.